Hey guys, what's up? So, in this particular lesson, we are dealing with important hot topics of science and technology. So, I'll be covering public health, and here is a new course on National Health Policy 2017. Because since it is 2017, it's such a big thing, National Health Policy, such a high level it is. So, I thought I'll cover this. This is presented by me, your friend Roman Saini. So when it comes to public and health, these are very very big terms. As an administrator, very very big like chunk of a district administrator goes in ensuring that basic public health is there. And if it does not get, then the hundreds of people can die. For example, in Gorakhpur, there were like 60-70 children got killed, and then basically it was all over the place, right? So nobody likes that public health system malfunctions, and it is the top priority of the district administration or the state administration or the central administration to ensure that the citizens receive adequate public health. So let us talk about the national health policy. This is the part 1. Okay. So before I go ahead, I'll talk about the course structure in detail, because these are the things which you need to understand in detail before we can move forward at all. So first of all, we'll discuss introduction in this particular lesson. What is national health policy? Why do we need a national health policy? What does it entail? What does it all include? Then we will cover the goal and aim of the national health policy. Then we will also see the key policy principles in the next lessons. What are these policies? What are the principles on which this policy is based? Then we will see the objectives of national health policy. Then we will see the specific quantitative goals and again the objectives, because otherwise if there is no goals, then the entire administration, what will they chase? Just remember, if it cannot be measured, there will be no outcome in it. Okay. So then you have policy thrust, which will ensure adequate investment. Then preventive and promotive health, organization of public healthcare delivery. So all these are important in policy thrust. Then you have national health programs like reproductive, maternal, neonatal, child, and plus A भी जुड़ गया. So this is basically adolescence services. And then you have child and adolescent health. Okay. So then intervention to address malnutrition and micronutrient deficiency. So all these are important. Then universal immunization, very very important, especially in light of missions like Mission Indradhanush, etc. It is taking a lot of prominence. Then communicable diseases like malaria, etc. These are communicable diseases, not in the strictest sense, but yes, they can be communicated from one human also to another human. But tuberculosis, pneumonia, diarrhea, all these are like really communicable disease. Then you have the non-communicable diseases. Non-communicable disease includes, let's say, diabetes. If you have, you cannot give it to me. You can't just throw it on my face and make me diabetic. If you are obese, I can't become obese because you are obese. If you have cancer, you can't give me cancer unless you have, let's say, cervical cancer and other things which are communicable. There are few cancers which are communicable. Then mental health, why it is important? Because in a country like India, which is a developing country, unfortunately, the mental health aspect takes a back seat. Like really, really it takes a back seat, which is a very sad scenario. And we need to take it to the upfront. People should talk about it. Even if you are in depression, people think it is better to die than talk about it. So that is unfortunately the scenario. And then we have population stabilization. So we need to stabilize our population, we need to control the population. And because it is burgeoning like anything. When I was a child, we used to say that by 2050 India will beat China. When I got into 6th class, they used to say by 2040 India will beat China. When I entered college, they said by 2030 India will beat China in population. Then in 2000, when I was in preparing for UPSC, they used to say 2025. Now some people are saying by 2022. So we don't want that kind of a glory race to number one. This is a bad number one race. So what do you mean by national health policy? So national health policy, like basically they do it every 20 years. Somebody wakes up and change the policy. So national health policy was there in 1983 and national health policy was there in 2002. So these were the two policies since the independence of India, and these were responsible for guiding the approach for the public health sector in India. But now this is completely outdated. And 2002 to 2017, what are the things which you used to do in 2002 now you don't do? There was no Facebook, there was no WhatsApp, there was no Instagram, there was no Oculus Rift, there was no PS4, but there was no MacBook, but you used to use them, right? Now we are using it. So now 14 years after the last health policy, the context has changed in the four major ways. Obviously we are talking about universal health coverage now. Earlier there was no concept like that. So first, the health priorities are changing a lot, and although the maternal and child mortality have rapidly declined, there is a growing burden on account of non-communicable diseases like obesity, metabolic syndrome, hypertension means high BP, diabetes, cancers, etc., stroke, cardiovascular disease, arthritis, and whatnot. And some infectious diseases are also coming back. The second important change is the emergence of a robust healthcare industry, which is estimated to be growing at double digit. What do you mean by this? So let's say the market of healthcare, assume it is 1 billion, so it will become 1.1 billion after 1 year. So it will grow at 10% minimum. So that do you mean by double digit? Double digit can be 10% also, 99% also, so it can vary between that. Now the third change which is growing which is happening is the growing incidence of catastrophic expenditure due to healthcare cost. For example, let's say you have a stroke, then your treatment might get involved 5 lakh 10 lakh rupees if it is complicated, and at the same time let's say you also have a heart attack and now the heart needs to be replaced, so that can again cost you like 2-3 crore rupees. So it is like huge expenditure. Aam admi cannot afford such an expenditure. So these are presently estimated to be one of the major contributors to the poverty. Now fourth is a rising economic growth will enable enhanced fiscal capacity. So this is the fourth one. So therefore a new health policy which is responsive to these contextual changes is required a lot. And National Health Policy 2017 has been built on the progress made since the last National Health Policy in 2002. So after 15 years finally we are back in the business. Now who has formulated it? It has been formulated, obviously the usual suspect, Ministry of Health and Family Welfare, Government of India, and it has been approved by the Union Cabinet on March of 15th 2017. Now we will discuss in short the goal or the aim of the policy. So envisage means we want the future to look like this. That is the envisaging. The attainment of the highest possible level of health and well-being for all at all ages through a preventive and promotive healthcare orientation in all development policies. Second point, universal access to good quality healthcare without anyone having to face financial hardship, and this would be achieved through increasing access, improving quality, lowering the cost. The primary aim of the National Health Policy 2017 is to inform, clarify, strengthen, prioritize the role of the government in shaping the health systems in all its dimensions. What does it include? So it includes investment in health, organization of healthcare services, prevention of disease, very very important. Promotion of good health. Yes, if you do prevention of disease and you promote good health, half of 90% of the conditions goes away. Now the same would be attained by the government through cross-sectoral actions, access to technologies, developing human resource, encouraging medical pluralism, building knowledge base, better financial protection strategies, strengthening regulation, policy assurance. Now this policy also recognizes the pivotal importance of sustainable development goals. So thank you for watching this lesson. Hey guys, what's up? So we will discuss the public health, the National Health Policy 2017. We have in last lesson we discussed the basics of the public health National Health Policy, and we also discussed basic introduction to the National Health Policy, that in past it was there in 1983, then in 2002, and what are the goals or the objectives of the National Health Policy and how come it is focusing on universal health coverage as of now. So that is the part of the public health. I will also deal with another topic, that is the universal health coverage, in a separate course, so you can watch that as well on unacademy.com. By the way, you can check out me and other educators courses on plus.unacademy.com and you can enroll in them. So the first and the foremost is National Health Policy, and this is the part 2 of the National Health Policy. I have already covered the part 1. So what is the structure? We have already covered the introduction to the National Health Policy. We have discovered the goal and aim. So we will discuss all these things later on and even these things later on. And in this particular lesson, we will discuss these bold things, that is the key policy principles of National Health Policy and what are the objectives of the National Health Policy. Okay. So let us talk about the key policy principles. Why do you need principles to make policy, by the way? Because without principles, you will not be able to inspire anyone. If you can't inspire or motivate others, they will not follow in your footsteps. They will not help you. They will not work to help you to realize your vision. So the key policy principles here includes professionalism, integrity, and ethics. So this is the most important thing. So you need to be professional, integrity, and ethics. This is the hallmark. So the health policy commits itself to the highest professional standards. Okay, otherwise quacks are not allowed. Okay, you will not only registered medical practitioners should do what they can do. only like Asha should not deliver the child, not such things. So highest professional standards, integrity and ethics has to be maintained in the entire system of healthcare delivery in the country, and it has to be supported by a credible, transparent and responsible regulatory environment. So this is related to the professionalism, integrity and ethics. First point. Okay, you can remember it by pi. Second is equity. What do you mean by equity? Equity means that each and everyone should have the equal chance to get this without any discrimination. That is mean by equity, wherein you minimize disparity, you minimize discrimination, you minimize any sort of negative treatment because of a particular caste, color, creed, anything on account of gender. Especially in gender, it happens a lot. Male children will always get the healthcare access, female children not so much. Similarly, poverty, poor people obviously cannot afford private hospitals, so here this will not be the case. Caste, people who are from lower caste, and they are facing a lot of issues even in accessing healthcare, by the way. Disability, other forms of social exclusion, even geographical barriers should not be a case. Okay, person sitting in Andaman and Nicobar also should have equal access as person sitting in New Delhi. Then affordability is the third point. So as the cost of the care increases, affordability, which is separate from equity, will require a lot of emphasis. So as you know, like 10% of the entire monthly consumption expenditure can sometimes go on health, and 40% of the monthly non-food consumption expenditure. So that is totally unacceptable. This is too much. This will push the people in oblivion. This will push the people in doing things which they don't want to do. It will push them in the trap of poverty. So as the cost of the care increases, affordability requires emphasis. This is the most important point. Now, catastrophic household healthcare expenditures, which are defined as health expenditure which exceeds 10% and 40%, are completely unacceptable. So please try to internalize this fact. This is not a joke that 40% of your non-food consumption is going on in health. This does not happen. This should not happen, because then you will fall into the poverty trap. Then the fourth principle is universality. So it is prevention of exclusions on social, economic or on grounds of current health status. So this is important. It has to be universal. Okay, in this backdrop, systems and services will be built such that they have to be designed to cater to the entire population, including special groups. Okay, let's say transgender group. There are so many special groups in India. You have to take care of all of them. Now it has to be patient centered, and quality of care has to be top notch. So it has to be gender sensitive. It has to be really effective, safe and convenient healthcare services has to be provided with dignity and confidentiality. So it has to be like, you need to have like proper privacy, rights of the patient, everything like that, that has to be accompanied. Otherwise, if it is not patient centered, then patient will not come. If you discuss, somebody is discussing their private life, depression, and then you make joke out of it, unfortunately it happens in India. So patient will not treat you well, they will not come to you, they will not respect you. Sixth is accountability. So financial and performance accountability, transparency in decision making, that's very important, and elimination of corruption in healthcare systems, both in the public and the private sector. So that is also very, very important, that is required. Then you have inclusive partnerships. So this approach would include partnerships with academic institutions, not for profit agencies and healthcare industry as well. So lot of like 7-pronged approach and much more than that. Then you have pluralism. So pluralism means patient who wants to choose, and when it is appropriate, they can not only go for the allopathic medicine, but they can also access Ayush care. Okay, like Ayurveda, Unani, Siddha, homeopathy, etc., yoga and naturopathy. So these based on documented and validated local, home and community based practices. So even plurality should be there, not just for allopathy medicine. The ninth point is decentralization. So the decision making cannot be top down here, it has to be bottom up in this case. So decentralization of decision making has to be there to a particular level, which is consistent with practical considerations and institutional capacity, and community participation in health planning processes has to be promoted side by side. So that is decentralization. 10th point is dynamism and adaptiveness. So constantly improving dynamic organization of healthcare based on new knowledge and evidence. You have to constantly change in this environment. You have to learn from the communities and from national and international knowledge partners and it has to be designed in such a way that it is very adaptive, otherwise it will become useless after some point of time. Now, once we have discussed the principles of the policy, now it is important to discuss the objective of the policy. These are very, very big terms, so let me try to explain them as much as possible. Progressively achieve universal health coverage. Right now, we do not have universal health coverage. If we want to have certain facilities that is not available as of this moment, as of 2017, and it is not there in India, but we plan to achieve it by 2022, where minimal services at least are available free of cost. Okay, where the person do not have to do any out of pocket expenditure. So that is meant by universal health coverage, and everybody pays for it. It is like everybody can give cess of 0.1%, 0.2%, but the poor people are covered. And reinforcing the trust in public healthcare system, unfortunately that is eroded because a lot of incidents, but we need to reinforce it back and align the growth of private healthcare sector with the public health goals, so that will also benefit us in the longer run. So if you do all these three things, the policy will become successful. So thank you for watching this lesson. Hey guys, what's up? So we are continuing the discussion of our public health, that is the National Health Policy of 2017, and it is an important topic of in science and technology. So this is presented by me, Roman Saini. Okay, so let us get started. So National Health Policy 2017, this is the part 3. We have already covered various things in the part 1 and part 2. So what are these things? Just have a little bit introduction. So we covered the introduction first, then we covered the goal and the aim of these policies. Then we had covered in second lesson key policy principles as well as the objective of the National Health Policy 2017. Now many people are wondering why we are learning this, because this will help you directly. They can ask you a question, write a short note on National Health Policy 2017, but these days they do you think the new national policy is in alignment with the universal health coverage, etc. So these kind of questions are asked these days. Now in this we will discuss specific quantitative goals as well as objectives, because if there is no goal in life, there is no way you can achieve what you want to achieve, because it is not quantifiable. If I say that you lose weight, it does not mean anything, because losing weight, from what point to what point will you call it losing weight? So you will quantify it saying that I'll lose 5 kgs in 1 month. So quantification is very much the need of the hour. And then we will cover the policy thrust, and then we will have the national health programs, etc. later on. So specific quantitative goals and observations and objectives here, these includes, so the indicative quantitative goals and objectives are outlined under the 3 broad components. So what are these 3 broad components according to you? So health status and program impact is 1, then health systems performance is 1, and health system strengthening is 1. So let me in brief talk about these 3. So what do you mean by health status and program impact? So you will have to see whether it is impacting or not. You will have to see various indicators, the IMR, MMR, all these things. Then health systems performance, how they are performing, and finally strengthening of the systems. Wherever there is leakage, wherever there is bad performance, wherever they are not up to the mark, there we intervene and make them stronger, strengthen these systems. So let us talk about health status and program impact first. So before we begin, let's say life expectancy and healthy life. So when the India got independence, the life expectancy was less than 40 years. Now it is 67.5 years. So obviously we have done something right? We have increased it almost 1.5 times, more than 1.5 times rather. So life expectancy has been increased from we want to increase from 67.5, which is currently, to 70 by the year 2025. But this is very less as compared to countries like Japan, where it is an 80 plus these days. Just remember, life expectancy of males is 99% cases it will be lower than the females in any country. So establish regular tracking of disability adjusted life year daily index as a measure of burden of disease and its trends by major categories by 2022. So that is daily. Daily means disability adjusted life years index. And then we want to reduce the TFR to 2.1. What happens at TFR 2.1? So at TFR 2.1, the population stops to decrease or increase. Basically it is stable. Whatever is the population, it stabilizes at TFR 2.1. So it is at national, subnational level by 2025. Then mortality by age and or cause. So that is also important. So reduce the under 5 mortality to 23 by 2025. So it is a huge task. Okay, very big task, that you want that, let's say if 1,000 children are born, So before they reach the age of 25, only 23 of them should die. 977 should live. And MMR from the current level to 100. Maternal mortality rate is total mothers who die during the process of childbirth per 100,000 live births. So less than 0.1% is 100 basically. It is exactly 0.1%. Then reduce the infant mortality rate to 28 by 2019. So just remember, infant mortality rate is included in under 5 mortality rate. Infant is up to 1 year, under 5 is up to 5 years. The years are different here, okay? So if it is 23, IMR has to be less than 23. It has to be less than 23. So reduce the neonatal mortality rate to 16. Neonatal means first 28 days. Infant means first 1 year. Infant will include neonatal, and under 5 means less than 5 years. Under 5 will include both infant mortality rate and neonatal mortality rate. And the stillbirth rate to single digit by 2025. So what they are trying to say is 9 or less. Then reduction of disease prevalence or incidence. So achieve the global target of 2020, which is also termed as target 90-90-90. Very, very important. Just listen to this principle of 90-90-90 related to HIV/AIDS. That is, the 90% of all the people who live with HIV know their HIV status. First point. 90% of all the people who are diagnosed with HIV, they receive sustained antiretroviral therapy. Second point. And 90% of all the people who are receiving sustained antiretroviral therapy, in them there is a viral suppression. So this is basically 90-90-90 related to AIDS. We also have to achieve and maintain elimination status of leprosy by 2018, Kala Azar by 2017, but right now Kala Azar cases are there and 2017 is already ending, so this is wrong. This is not achieved. Lymphatic filariasis in endemic pockets by 2017, it is still there, so it is not achieved. To achieve or maintain a cure rate of more than 85% in new sputum positive patients for TB, sputum means thuk, and reduce the incidence of new cases to reach elimination status by 2025. Very, very hard target to achieve. To reduce the prevalence of blindness to 0.25 per thousand by 2025 and disease burden by 1/3 from the current levels. To reduce the premature mortality from cardiovascular disease, cancer, diabetes or chronic respiratory disease by 25% by 2025. Try to remember these goals as much as possible. And when it comes to performance, so coverage of health services, so increase utilization of public health facility by 50%. Then antenatal care coverage to be sustained above 90% and skilled attendance done above 90%. More than 90% of the newborns are fully immunized by 1 year of age. Meet need of family planning about 90% at national and subnational level. All of this is by year 2025, by the way. And 80% of known high BP patients and diabetic individuals maintain controlled disease status. Now cross-sectoral goals related to health also includes relative reduction in prevalence of current tobacco use by 15% and 30% by 2025. Reduction of 40% in prevalence of stunting. Access to safe water and sanitation to all by 2020, Swachh Bharat Mission. Reduction of occupational injury by half. And national state level tracking of selected health behavior. And then you also have the health system strengthening. So increase the GDP from 1.15% to 2.5% by 2025. Increase state sector health spending to more than 8% of their budget by 2020. Decrease in proportion of households facing catastrophic health expenditure from the current levels by 25% by 2025. Then you have health infrastructure and human resource. So ensure availability of paramedics and doctors as per the Indian Public Health Standard norm in high priority districts. Increase community health volunteers, establish primary and secondary care facilities. And finally, health management information. Ensure district level electronic database of health related information. Strengthen the health surveillance system and establish registers for disease of public health importance. And establish federated integrated health information architecture, health information exchanges and national health information network. So thank you. Hi guys, what's up? So we'll discuss the National Health Policy 2017 and we are continuing this course, and I hope that this helps you a lot. So National Health Policy, this is 2017 part 4. So let us get started. We have already covered the introduction. We have covered the goal and aim in the first lesson. Then we discussed the key policy principles and objectives in the second lesson. And in the last lesson, I described all the specific quantitative goals and objectives. So once we are done with this, we will move towards the policy thrust, that is ensuring adequate investment, preventive and promotive health. Very, very important. There are two different concepts, prevention and treatment. Then organization of public health care delivery. So let us get started. What are these thrust areas, so-called thrust areas of the policy? Thrust areas means where you should put specific emphasis, etc. So that becomes the thrust areas. So ensuring the adequate investment. So the policy basically proposes a potentially achievable target of raising public health expenditure to 2.5% of the GDP in a very time-bound manner. So this is ensuring adequate investment. This is the first point. Then you want to increase to 2.5%. Currently it is less than 2%. Then preventive and promotive health. So how do you do this? How do you prevent health? How do you promote health? So you can do it either by information, education and communication, or you can take active intervention. Let's say if you want to prevent the occurrence of dengue and malaria, what you have to do is just kill all the mosquitoes, make them sterile, make sure that they don't reproduce, etc. So this policy identifies coordinated action on 7 priority areas for improving the environment for health. The first is Swachh Bharat Abhiyan, that is Clean India Mission. Second is you have a balanced diet, you have a healthy diet, you do regular exercises. So if you can do this, then it is great. Then addressing tobacco, alcohol and substance abuse. So that is very, very important as well. Then you have Yatri Suraksha. Yatri means passenger, Suraksha means protection. So preventing deaths due to rail and road traffic accidents. If you live in India, you know that how many people every year, like hundreds of people lose their life because of railway accident, and lakhs of people lose their life because of RTA. What is RTA? RTA is road traffic accident. Okay, there is huge trauma to head, spine, etc., and it almost become virtually impossible for them to survive. And then you have Nirbhaya Nari. Nirbhaya means fearless, Nari means women. So it is action against the gender violence. So that is how you can prevent and promote health, prevent diseases and promote health. So these are several measures which are identified by the policy. So these are 5 of these priority areas. Then you have reduce stress and improved safety in the workplace. So like in factory settings, especially in industry setting, like there are a lot of industrial accidents where people tend to lose their limbs and lives. So in that kind of environment, we need to reduce stress. We should not ask them to work for 16 hours straight. We should provide them ample facilities. We should provide them treatment facilities. We should provide them proper equipment, safety equipments to work with. In case a mishap happens, then they should be rushed to hospital very, very fast. Then the 7th and the last point, which is the emphasis point of this policy, is to reduce indoor and outdoor air pollution. Now, what do you mean by these two things? So, for example, you might live in a very clean village where there is absolutely no pollution, yet inside your house you use basically cooking for wood is used there, so it creates a lot of carbon dioxide, carbon monoxide, methane generation. You might use cow dung also for the production of heat so that you can cook. So despite the fact that there is no outdoor pollution, still you have a lot of indoor pollution, and it is one of the biggest killer in the entire world, the indoor air pollution. Second point is you might live in a posh area in Gurgaon and your house will be absolutely neat and clean. You have 10 air purifiers, but as soon as you step out, you know that the air is hazy and there is a smog outside and you are not able to see, your eyes are irritating and your lungs, you are coughing out. So that is the outdoor air pollution. So do you realize the difference between outdoor and indoor pollution? That's good. So the policy also articulates the need for the development of strategies, institutional mechanisms in each of these 7 areas. What are these 7 areas? Swachh Bharat Abhiyan, balanced healthy diets, regular exercise, addressing tobacco, alcohol and substance use, Yatri Suraksha, Nirbhaya Nari, indoor outdoor pollution, and reduce stress and improved safety in the workplace. So this policy articulates the need for the development of strategies, institutional mechanisms in each of these 7 areas to create Swasth Nagarik Abhiyan. Swasth means healthy, Nagarik means citizen, Abhiyan means, let's say, a mission. So they want to create healthy citizen mission. So it is a social movement for health. Everybody should be healthy. Now you also have health impact assessment. So to see whether it is working or not of existing as well as the emerging policies of key non-health departments that directly or indirectly impact health would also be taken up, so that we know exactly if they can also help us or not. Then organization of public healthcare delivery. So that is also very, very important. So let us see. So the policy basically proposes 7 key policy shifts in organizing the healthcare services. So let us see these 7 policies here. So the first and the foremost is in the primary care, from selective care to assured comprehensive care with linkages to referral hospitals. Now I have been worked as a doctor for some time, so I know what they are talking about. So primary care basically means you have a PHC, primary health center, where you have just an intern sitting there. He is not even a full doctor like I was. I was the highest doctor there sometimes. Like what could I do? I can deliver a baby, I can give basic medicines, I can't do heart surgery if required, I can't remove their appendix, right? So I can only give selective care in PHC. But now what they are trying to say is ki don't give just selective care in a PHC. You should give assured comprehensive care. And if you are not able to treat yourself, you should be able to refer the patient. So you should be referred to the patient to referral hospitals. So for example, in AIMS there was a PHC in Dayalpur in Haryana. So from there we used to refer to them CHC Vallabhgarh. CSE is basically Community Health Center. And then there is a hospital, Badshah Hospital, and it is very known for TB. So they used to go to Ghaziabad, that is the district hospital, and even then, if there is no cure, then they used to go to tertiary care center, that is AIMS. Now, in secondary and tertiary care, from an input oriented to an output based strategy purchasing. So here, like you want to do not to buy two MRIs, but rather your goal should be to, let's say, get rid of Japanese encephalitis. So the goal has to be changed. It should be output based strategic purchasing. Now the third point is in public hospitals from users fees and cost recovery. That is earlier there, right? People used to be charged even in government hospitals. So obviously they can't pay. Now we have to give them assured free drugs, diagnostic and emergency services to all. So each and every one of them should be given assured free drugs, diagnostic services, emergency services. Everyone should receive that. So this is the third point because universal health coverage entails it. In infrastructure and HRD, from a normative approach to targeted approach to reach the underserved areas. So you have to make sure that doctors are available in those areas so that these underserviced areas can be treated properly. Then fifth point is in urban health from token interventions to on-scale assured interventions to organize primary healthcare delivery, referral support for urban poor. Then collaboration with other sectors to address wider determinants of urban health. It is also advocated. And in national health program, integration with health systems for program effectiveness and in turn contributing to strengthening of health systems for efficiency, and in Ayush services from standalone to a three-dimensional mainstreaming. So we'll continue discussing the public health care. Thank you. Hey guys, what's up? So this is the final and the fifth lesson in the public health and national health policy is the topic of our discussion, and in this lesson I'll cover everything which you need to know about the national health policy, and finally we'll put it to an end. So this is presented by me, your friend Roman Saini. So this is the national health policy 2017, the part 5 of it. So when we talk about national health policy, we covered the introduction, we covered the various goal and aim of these policies, then we covered the key policy principles, objectives, specific quantitative goals and objectives. Then policy thrust, like areas like ensuring adequate investment, preventive and promotive health, organization of public healthcare delivery. And finally, we will cover the national health programs like reproductive, maternal, neonatal, childhood plus adolescent services, child and adolescent health, interventions to address malnutrition and micronutrient deficiencies, very important concept of universal immunization, communicable diseases, non-communicable diseases, mental health and population stabilization. So all these points become really important. So let us get started. So various national health programs are there. Obviously we cannot discuss that because each and every program itself will last for half an hour, but I will cover as much as I can and I will cover it as fast as I can, yet giving the basic essence or crux of that particular program. So first of all, RMNCH plus A. R stands for reproductive, M stands for maternal, N stands for newborn, C stands for child, and A stands for adolescent health. So these are the services which are provided here. So literally everybody is covered here. Okay. So this policy aspires to elicit developmental action of all the sectors to support maternal and child survival, because if you factor in all of these people, like newborn child obviously is related to child, reproductive, maternal is related to mother, and adolescent health, because if you catch women young in their adolescence when they are likely to develop anemia and all, so at that particular point if you do the intervention, if you provide them weekly iron folic acid supplementation, if you talk to them about menstrual hygiene, if you talk to them about contraceptives, if you talk to them about birth control, at that age if they can do it and they can delay pregnancy from let's say 15 to 25, then the maternal child survival is drastically higher. Okay. Second is child and adolescent health. So this policy endorses the national consensus on accelerated achievement of neonatal mortality targets and single digit stillbirths rates through improved home based and facility based management of sick newborns. So what they are trying to do is that neonatal mortality target is basically, it should be single digit, and single digit means that less than 1000 neonates who are born, they should not die within 28 days of their birth. And how you can do is, you can do it either by facility based management of sick newborn, basically facility means PHC, CHC, etc., or you can improve the home based management wherein they get the best of the treatment in their home itself. Then there are interventions to address malnutrition, micronutrient deficiencies, so you can take a lot of interventions to do that as well. So what do you do for this? So for malnutrition you have so many schemes. Each and every child who comes to the hospital, we give them a proper nutrient chart. That chart is given for 6 months, and if you have micronutrient deficiency, you can be given injections, tablets, etc. Then universal immunization is basically, if you can prevent the occurrence of the disease, you will spend a lot of money, like it is happening in polio right now, in treating the disorder. So priority in universal immunization will be to further improve the immunization coverage with huge quality and safety focus, improve the vaccine security as needed by the National Vaccine Policy of 2011, introduction of newer vaccines based on epidemiological considerations, etc. And the focus will be to build upon the success of the mission Indradhanush and strengthen this particular mission. So that is your universal immunization. Then you have communicable diseases. So the policy recognizes the interrelationship between communicable disease control programs and public health system strengthening. Okay. Now when it comes to controlling of tuberculosis, so the policy obviously know that HIV and TB co-infection happens. So if you are suffering from HIV, your immune system goes down, and there is much likely chance that you can suffer from TB as well. Then there is increased incidence of drug-resistant tuberculosis, because it is a very key challenge in control of tuberculosis. Now the National Health Policy calls for more active case detection with greater involvement of private sector, supplemented by preventive and promotive actions in the workplace and living conditions, etc., so that the disease does not occur in the first place itself. Then control of HIV AIDS. Okay, so then control of HIV AIDS. So while the current emphasis on prevention is there, but policy also recommends focused intervention on high risk communities, okay, like men having sex with men, transgenders, etc. Then prioritize geographies, etc. And there is a huge need to support care treatment for people who live with HIV AIDS through inclusion of, there are various lines of antiretroviral treatment. So first, second and third line of antiretroviral, hepatitis C, other costly drugs into the essential medical list. Then you have leprosy elimination, so that also need to be done. So we have to carry out leprosy elimination in the proportion of grade 2 cases amongst new cases. It will become the measure of community awareness, health system capacity, etc., and keeping in mind the global goal of reduction of grade 2 disability to less than 1 per million by 2020. And accordingly, the policy envisages proactive measures targeted towards elimination of leprosy from India by 2018. Then there is vector-borne disease control. So here the policy recognizes the challenges of drug resistance and malaria, which should be dealt with by changing treatment regimes with logistic supports, as the case may be. Then there is new national program for prevention and control of Japanese encephalitis. Then there is acute encephalitis syndrome. They should be accelerated with strong component of intersectoral collaboration. So vector-borne, basically diseases like chikungunya, dengue, kala azar, all these are vector-borne diseases where there is an insect or some other vector who transmits the disease-causing agent. Then non-communicable disease like diabetes, hypertension, they are chronic diseases. So policy wants them to be halted and reverse the growing incidence of chronic diseases. And policy recommends to set up a National Institute of Chronic Diseases, including trauma, to generate evidence for adopting cost-effective approaches to showcase the best practices. And it will also support an integrated approach where screening for the most prevalent non-communicable diseases with secondary prevention would make a significant impact on reduction of morbidity and preventable mortality. Then you have the mental health. So this policy will take into consideration the provisions of the National Mental Health Policy of 2014. Finally, you have the population stabilization. So we want our population to stabilize. We don't want to be the number one in this, but unfortunately within next 4 or 5 years we will be number one. So it recognizes you have to need to have improved access, education, empowerment. It would be the basis of successful population stabilization. And the policy imperative is to move away from camp based services with all its attendant problems of quality, safety, dignity of women, to a situation where these services are available on any day of the week or at least on a fixed day, and proportion of male sterilization to at least 30% from current 5% can be done. So I guess you like this course. Thank you for watching this. Have an awesome day. It will really help you in your essay writing.